Hello, everyone, and welcome to our event, Self-Care, Women at the Center of Their Health. My name is Anna Mansari, and I am the Donor Engagement Officer at Doctors Without Borders in Canada. I am joined today by an incredibly knowledgeable panel of speakers. Before we begin our event, I do want to take a moment to reflect with you about the land that we are on. As we join each other from all over Canada and the world, I encourage you to think about the people who lived on and cared for our land before us. I'm speaking to you from Brampton, Ontario in Canada, which Indigenous peoples, particularly the Anishinaabe, Huron-Wendat, and Ojibwe peoples inhabited and cared for thousands of years before I stepped foot here. I invite all of you to join me in reflecting and relearning the history of the land each of us now call home, and how we can honor the Indigenous people who cared for this land before us. Thank you for joining us once again for our Self-Care Women at the Center of Their Health event. MSF is an international Nobel Prize-winning medical humanitarian organization. We provide emergency medical care to people affected by disaster, conflict, epidemics, and those excluded from healthcare. This week also marks the one-year anniversary of the COVID-19 pandemic in Canada, which has further highlighted the needs for accessible healthcare, not only in our own backyard, but across the world as well. We have a great panel of speakers who are going to talk about the impact of COVID-19 on women and how self-care has been a way in which women can advocate for their own health. I would like to introduce our lineup of speakers. First, we have Joanne Sear. Joanne is an association member of Doctors Without Borders Canada and Switzerland. She has worked with Doctors Without Borders for 10 years and just recently completed a role in Switzerland as the advisor for patient education, health promotion, and community engagement. Joanne has been a strong advocate for adapting patient-centered care and sexual and reproductive health activities to the needs of vulnerable populations. Joanne will be moderating our discussion today. Thank you for joining us, Joanne. Next, we have Colleen Docherty, who has a master's in public health. She joined Doctors Without Borders in 2015 and has worked as a registered nurse, focusing on responding to sexual violence in Afghanistan, Bangladesh, Ethiopia, Iraq, Papua New Guinea, Sierra Leone, South Sudan, and Mozambique. She has led research on sexual violence against men and boys in Syria and Turkey, and has facilitated training on clinical management of rape and intimate partner violence in Nigeria with the Norwegian Church Aid. And last, but certainly not least, we have Judith Mutangerwa, who has pre-recorded her presentation since she is currently in Zimbabwe. So we'll be seeing her presentation after our conversation. She is a passionate humanitarian from Zimbabwe who joined Doctors Without Borders in 2009. She has done extensive work focusing on HIV, TB, and non-communicable diseases, as well as health emergencies. Judith worked in Malawi with populations at high risk of contracting the HIV virus, including female sex workers, and recently completed her second mission in Beira, Mozambique. So thank you to all of you for joining us here today. And with that, I'm going to leave it to Joanne to kick off our discussion.
Pardon me, I was muted. I'm very sorry. Welcome to everyone, all our viewers. We're here to talk about self-care, women at the center of their care. Today, I'm going to give you just a little bit of an overview. We're going to have our speakers, our panelists discussing some of their experiences. We have various experiences to share about the issue of self-care. Just to give you a little bit background on this, please, if you can go to the next slide. So this is a small photo about a family in somewhere in the Middle East. I'm not sure if it's Pakistan or Afghanistan, but we're looking at today self-care, that the idea that we can expand women's access to healthcare by providing additional options that overcome social, economic, logistical, and other barriers. We have a lot of experience in working in maternal child health and in sexual reproductive health in many places in the world. And what we've noted is how important it is to recognize there may be portions of the population, depending on the context, depending on culture, depending on age, that could influence women's ability to access care. And so self-care is not a new idea, but the idea is to integrate it into the healthcare options that we offer today. So if you can go to the next slide. This, some of you may be familiar with, it's a sort of global map of MSF activities. The red areas are all regions in the world where we conduct MSF projects, and we have MSF missions. And we'll be talking about, I'm using MSF to speak of Doctors Without Borders. By the way, this MSF is, we're known by the French name globally, internationally. So where you see these arrows, Central America, Middle East, Democratic Republic of Congo, Malawi, Mozambique, and Eswatini, these are all areas where we've implemented self-care interventions to complement the kinds of activities we already have existing. So we'll be focusing quite a lot on those, specifically some of those that Judith will be talking about her direct experience. These are the ones we've highlighted for this International Women's Day. Next slide, please. So allowing women and girls to contribute to their own health and well-being. This is a subject near and dear to my heart. We're talking not only about allowing, but specifically empowering women and girls. We want to give women and girls more options, more understanding, more awareness about where they can access, how they can access care, and how they can develop trust in the kinds of options that they have to them. And so this is not about us entrusting them so much as it is about them trusting us with giving reliable information. So here we have the WHO definition. The World Health Organization speaks of the ability of individuals, families, and communities to promote their own health, prevent disease, maintain their health, and cope with an illness or disability with or without the support of a healthcare provider. We know that many people do things on their own to learn about and to find options or treatments on their own. And so the idea here is understanding what people are seeking, what they need, and how we can respond to that need and give relevant and adapted care, including self-care options. In MSF, we aim to offer a patient-centered approach, supporting people with the knowledge and skills to undertake self-care safely and retain access to formal health services when they need or wish. We underline safely. We want people to have reliable information and information that they can trust. And this, in this year of coronavirus has been particularly salient. This year, we've seen how much there's misinformation or deliberately misguided or misleading information, and how much it's been important to try and direct people to trusted sources of information. And we try to always support and promote information that is evidence-based and based in our knowledge and understanding of the contexts in which we work. So I will say that part of this increased in focus on self-care, it's not new, it's an increased in focus on self-care, comes from the experience that we've seen that we are missing segments of the population, perhaps, particularly those who are most vulnerable, who are least likely to access public healthcare systems or private healthcare systems. And so this is part of the effort we've been making over the last few years to promote more methods people can take care of themselves with only punctual support from the healthcare services that may be available to them. So this is in my work. I've done a lot of work with local populations, training local people, local staff, and local community members to be the ones who provide peer support, peer education, and provide a cultural understanding and adaptation of what is most needed and most trusted on behalf of the local communities. So next slide, please. So here I've shown 2 examples of self-care. We include the first point, self-care that we can, the first point, please, is self-management, a global term that can encompass also the idea of self-care. So self-management, we've used it a lot in our programs where we work with people with chronic diseases or people with new diagnosis of an illness. So it can refer to the medication we offer, the treatment we offer, self-injections, and administration of medication. So that first photo you see on the left is a peer counselor teaching how to take ARVs. ARVs are antiretroviral medications to treat or prevent in an emergency infection by HIV. And we've taught some peers, people living with HIV, to educate and support people newly diagnosed with HIV or people living a long time with HIV to better self-manage their care. On the right, you see in the picture a demonstration of what's called the Cyana press for self-injection. We have a project in Congo that Judith will talk about. The Cyana press is a self-administered or demonstrated prick in the thigh, basically, of a Depo-Provera contraceptive that lasts 3 months. We can give these devices to women to then self-administer at her 3-month date or 6 months date. And this has been important in some of our work where there's a lot of people on the move, where people are displaced from their homes and they need a method that they can bring with them. Second point, we can include self-testing, ranging from sampling and screening to diagnosis, collection and monitoring. An example of that is self-testing for HIV, which Judith will talk about also. There's self-swabbing, we call it, for HPV, human papillomavirus, in women, particularly women living with HIV have greater risks. And so learning these techniques have helped them to get earlier detection and earlier treatment. The last point is self-awareness, self-efficacy, self-determination. These are all terms in the more global sense we know self-care. And this is what allows women to be empowered to take control over their own health. And so having access to information, having the skills to use that information, and having the self-determination, that is the wherewithal and the information they need to consent to treatment, to understand the pros and cons, the risks involved, and also the benefits for them, and use that information for their own health, for their family's health. So with that, I will send it over to you, Colleen. Colleen will continue with some of her experience she's had as a nurse manager in multiple projects. Thanks, Colleen.
Thank you. So first, I'm going to start by speaking about the barriers and obstacles to care. So this is one of the many reasons that we are looking at expanding self-care interventions, because we know that there's many challenges in accessing healthcare. So in many places we work that are remote and very rural, healthcare simply does not exist or is very far away. So for example, in South Sudan, where I've worked, the closest health facility could be days walking away. Or in Sierra Leone, in rural areas, women and girls might need to get on the back of a motorcycle and take a half day through muddy roads to get to the closest health facility. And this also involves the cost of transport, the time away from caring for children and their families, and this can be a barrier. But we also know that in conflict, health infrastructure is often non-existent or insufficient or damaged. And this is a significant barrier to healthcare. When I worked in Iraq, I was there after the conflict when people were returning to their communities. But during the conflict, the health facilities had been bombed, had been damaged by shelling and gunfire. And so people returned home, but did not have any health care to return to. So it's also during and after conflict, rebuilding health infrastructure is important. So people don't have access to healthcare in conflict settings and in displacement. So we see when women are traveling through North Africa to Libya to the Mediterranean to get to Europe or through Latin America, when they're migrating or displaced, they don't have access to care during pregnancy, access to contraception, basic care that's needed. In many places around the world, women and girls lack the decision-making power over their own health, over their ability to get to the health facility. For example, they might need permission or support from a male family member, a husband, or a father just to pay for transport, to leave the family for the day, and especially when there's stigma and control over women's sexuality, and this creates a problem for accessing sexual and reproductive health care, such as contraception for adolescent girls or safe abortion care. And we also know that people around the world are excluded from healthcare or face discrimination. It might be refugees living in a new host country, or adolescent girls seeking contraception might be turned away, or sex workers might experience discrimination, or LGBTI folks, lesbian, gay, bisexual, and trans individuals might face discrimination. This can also be disrespectful and judgmental treatment by healthcare workers, a lack of privacy and confidentiality, or even harmful or coercive treatment. This is something I've seen working with survivors of sexual violence. They fear the shame and stigma that they might experience if they do go to a health facility, so they might avoid it altogether and not seek out healthcare. And so this has all been worsened, as we know, in Canada. Access to healthcare can be more difficult during this pandemic, but this is true around the world. So next slide. So as a result of these barriers to healthcare, women lack access to sexual and reproductive health care. 1 in 4 women around the world don't have access to a reliable contraceptive method, and over half of the people living with HIV are women. We also know that unsafe abortion is a major cause of death, 1 in 5 reasons for maternal mortality around the world because of a lack of a safe alternative. So next slide. So these are some of the reasons we are promoting self-care. As Joanne mentioned, self-care has been something that's been done for thousands of years, whether or not it's women managing their pregnancy symptoms, traditional birth attendants attending births. Maybe some of you can think of ways that your grandmother took care of her own health and her family's health. We also know self-care comes from a history of Black feminists in the 60s and 70s who were excluded from healthcare and took control of their health into their own hands and got health information and delivered healthcare to themselves and their communities. So we at MSF and also WHO, the World Health Organization, is recognizing self-care as an important intervention to give agency and autonomy to women and girls to control their own health. We need to trust that women and girls know their needs and are best suited to make decisions. So we give them information on how to make decisions and to actively participate in their healthcare. And we promote them to have control and choice over how to prevent and test for and manage illnesses and diseases. So I'll give some examples of how MSF is working to promote self-care interventions for sexual and reproductive health. The first one's in Eswatini, a country in Southern Africa with one of the highest HIV prevalence in the world. With this HIV prevalence, HIV testing is incredibly important to ensure people get a diagnosis early on and access to treatment. And so with stigma related to HIV, it might be difficult for people to go to the health facility. So we are promoting these oral tests. It's a test that you can swab in your mouth of your gums and wait just like a pregnancy test at home for 1 line or 2 lines, and it takes about 20 minutes. So we give health information sessions at the health facilities and send people home with these tests so they can do it comfortably and discreetly in the privacy of their own home. And then if people you can go to the next slide. If people do have a positive test result, they can either call our hotline or come back to the clinic to be started on antiretroviral therapy. In addition, for people who are at high risk of acquiring HIV, such as sex workers or people in a relationship with someone with HIV, we are supporting them to take PreExposure Prophylaxis, or PrEP. So this is a pill someone can take every day to prevent the risk of acquiring HIV, and we support them to do this. Then in Palestine, you can go, oh yes, the next slide, to this slide, sorry. We have a mental health project that we offer individual and group counseling to people with mental illness and to survivors of violence, including intimate partner violence. But as many of you know, group sessions and sessions in person are more difficult during the COVID pandemic. So you can go to the next slide. And this has also increased gender-based violence around the world. It's being called the shadow pandemic. Women are trapped at home with their abusers with no escape and without the normal social support they have. So we've adapted. We have telecounseling where women can call in our counseling line and get support on how to manage anxiety or depression, and also talk about safety. And we listen to them. We know that they know the best on how to stay safe in a situation of violence. So they've suggested code words so that they can call. And if they say a code word, it means that their husband might be home and we'll switch to another topic. And so this telecounseling, we've actually had increased retention during COVID. So it's something we will continue after, so that people have multiple options, both in person and telecounseling. And so, as I mentioned, unsafe abortion is one of the top 5 causes of maternal mortality around the world. You can go to the next slide. So 22,000 women and girls die every year from unsafe abortion, and over 7 million women suffer complications. The vast majority of this is in low and middle income countries where there is not access to a safe alternative. So we provide safe abortion care as a life-saving component of our reproductive health care. And medication abortion can be a safe, simple, and self-managed way to have a safe abortion. So we are looking at how we can promote this as a self-care intervention. So in some settings, women or girls can come to the health facility and we can provide information on the medication, on how to take it. It needs to be taken at multiple doses, provide education about how about the process and completion of a safe abortion, and then they can take the medication home. And so they can self-manage a safe abortion themselves and then monitor for any very rare complications and return to the health facility if needed. So this helps to put the control in women's hands and also makes it more accessible when staying at a health facility for a prolonged period of time can be a challenge. And then in the Democratic Republic of Congo, another method we're looking at is this self-managed injectable contraception that Joanne mentioned earlier. So it's similar to Depo-Provera, which is an intramuscular injection. This is a subcutaneous injection, so it can go in the fat, in the thigh. We can teach women how to use it at the health facility. They can self-administer it. They can take it home. So we give 3 to 4 doses. They can take this home, give it to themselves every 3 months. So they can have up to a year of contraception. And this can be really life-changing for women who live at a distance to the health facility, where conflict can make travel a challenge in the Democratic Republic of Congo. And it also importantly reduces unsafe abortion as a result of unwanted pregnancy. So it really can be life-saving. A last example is in Zimbabwe. We know that cervical cancer can be detected early and managed, but without that early detection, many women die from cervical cancer. So this is something that's been happening in Zimbabwe. But last year, we did a research study looking at self-swabbing of the human papillomavirus. So giving women the swab to swab themselves for this virus that's an early precursor to cervical cancer, and comparing it with swabbing from a nurse. And we found that both by a nurse and by the woman themselves is equally effective, but women were more comfortable swabbing themselves and would recommend this to a friend. So this can also significantly expand early diagnosis for women unable to access healthcare, and then ensure that they're identified and treated early to save lives from cervical cancer. So we will move on to Judith's presentation, but I look forward to answering your questions or discussing more in our Q&A session.
Colleen, will you allow me to introduce us again so that, are you hearing me?
We can hear you, or I can hear you, Joanne.
Okay, you can hear me. I've somehow lost the connection. We wanted to introduce ourselves once again. We're from Doctors Without Borders, Médecins Sans Frontières. We're here to talk about self-care. I am moderating this session today. My name is Joanne Sear, and I'm a psychologist and a specialist in health promotion, community engagement, and patient education and counseling. You've just heard from Colleen Docherty, who is a nurse who's worked in many of our SRH programs and gave us some examples, very good examples. Thank you, Colleen, on some of the self-care interventions we're doing. And now we'll introduce a clip to you, a video clip, which is by Judith, a field worker who is currently in Zimbabwe. She pre-recorded her session because unfortunately she couldn't join us online. So if you could go ahead and show the video. Thanks everyone for joining us.
Hello, my name is Judith. I've been working with MSF since 2009. I worked in Zimbabwe until 2017 as national staff, and then I went on a mission. And I've been working in 2 countries for the past 2.5 years, where I've been working with populations that are at high risk to HIV infection. I'm going to share my presentation, and I'm sorry that I had to pre-record it because I have internet challenges, so I couldn't do it on the day of the event. So I'm going to start to share my presentation. Just some background into the projects that were supported by MSF, and I've been working in those 2 projects for the past 3.5 years. These are projects that are focusing on HIV and sexual reproductive health services for populations that are at risk of contracting HIV. These include female sex workers, transgender women, and men that have sex with men. These are the key populations that we were working with. Their major health needs include HIV prevention services. They require HIV treatment since they're more likely to be living with HIV. They also require contraceptive services. They require safe abortion care services. They're also more likely to face sexual gender-based violence, so they need SGBV services. Why did MSF opt for a self-care model? There might have been several reasons, but here I'll highlight 3 major reasons. Number 1 was the restrictive national policies. For example, safe abortion care in one country was illegal. And we know that safe abortion care is one of the major health needs of female sex workers. So MSF had to adapt. Oral self-testing was legal in one country, but it was only offered at health facility under observation. And this for MSF was a key activity because key populations have to be retested every 3 months for HIV as per World Health Organization guidelines. Secondly, and also quite importantly, there was a huge demand for these services from our beneficiaries. Therefore, MSF had to adapt their approach. Thirdly, there was limited access in conventional health facilities that are supported by Ministry of Health. Some facilities were charging user fees. Some user fees were official, some were not official. They were more like bribes that patients had to pay to access services. Then also there was the issue of non-flexibility in terms of opening hours. So for key populations, it was a big barrier. There were also issues of stigma and discrimination that were often reported by our target population. And this was also considered a huge barrier in terms of accessing healthcare services. What approach did MSF use? MSF, the self-care model that MSF used was rooted in two major pillars. Number one was the peer-to-peer approach. MSF recruited individuals from amongst the target population. So in these projects, we had sex workers as working full-time for MSF, MSM, transgender community as well were represented, and they were working to provide basic HIV and sexual reproductive health services amongst their networks. They were an entry point for basic health service delivery amongst populations at risk. The second approach was task shifting. Task shifting involves redistribution of tasks from people that hold high qualifications to less qualified people within the workforce in order to make sure there is efficient delivery of healthcare services. And this was one of the two major pillars of the MSF approach in the two projects. A peek into the self-care services that were provided in these two projects. The peers conducted health education sessions within the target communities. They provided a full course of post-exposure prophylaxis at community level. Initially, the post-exposure prophylaxis provision was only done as an initial dose, while the rest of the course was provided at health facility level. But there were issues again in terms of delays. So MSF adapted and empowered the peers through training, through support to provide the full course at community level. The other opportunity also to provide full course for post-exposure prophylaxis was presented by the COVID outbreak early in 2020, where the teams had to keep track of target communities, and our peers were trained to provide the full course and also to provide the necessary follow-up. Safe abortion care was also task shifted to the peer, from the midwife to the peer. It took a lot of investment into the peer in terms of training so that they could do it, and they got remote support from a midwife, and they did it perfectly well without any complications. They provided the health education, they dispensed the medication, and they provided the necessary follow-up. And in case of a referral, if at all there was any complications, they did the referrals. Then the peer-led oral self-testing, while it came as a study, it was one major activity that was requested and demanded by the target population. And we couldn't do it as a routine activity because Ministry of Health did not approve. Therefore, we did it as a study, and we did it amongst about 50% of our active target population. And again, the peers provided the health education, they provided the kit, they distributed the test kit. And The target population conducted the self-test on their own without support, without observation. They did it at their own convenience. There were some barriers that we faced in terms of providing self-care to our beneficiaries. Number one is the restrictive legal frameworks in one of the contexts where we were working. There were policies that did not quite support safe abortion care, for instance, even in a health facility for the generality of the population, it wasn't accessible. But here we were, as MSF, we were faced with a need that was expressed and also observed, and we had to take a stand. So as MSF, we continued with our advocacy work to try and influence opinion in terms of the legal framework, but we also went on to empower the peer educators to make sure they provided the service amongst their network. Then also one noted challenge was sometimes the lack of a shared vision within MSF teams themselves. You know, these are innovations, and there's some people that were reluctant to give these tasks to less educated, less qualified peer educators. So eventually we realized that there is need to have a common vision within the teams in order to make self-care possible within our projects. We drew a number of lessons from the two projects as MSF. What we learned is that self-care improves health outcomes. For example, in the HIV self-testing study, our retest rate jumped among the study population from below 50% to 88%. It was a huge success, and it was readily acceptable by the community. We also learned that peers are central in HIV and sexual reproductive health programming for populations that are at high risk of infection. Hence, they need to be given their space. They need to be empowered. We also learned that it's important to work with motivated peers who are passionate, and we need to invest in we need to invest in training so that they take charge of their own health. I will share the little story of Amanda. Amanda is not a real name. She was a peer that was working for in one project. Amanda, at some point, needed safe abortion care, but she couldn't access it because of the reasons already mentioned of user fees and so on, illegality. So she used one of the commonly touted traditional methods. She used the cassava stick that she shoved up her privates, and she managed to terminate her pregnancy, but she also almost lost her life, and she had to be rushed to a health facility. So when Amanda shared this testimony, she indicated that she didn't want to see any of her peers going through the same problems that she faced, the problems of access, the problems of having to resort to unsafe methods of terminating pregnancies. And this is what drove her, this is what motivated her as a peer to provide safe abortion care to her peers. It was not out of coercion from MSF, and it was really based on willingness, and any staff member that didn't feel like participating, they were respected, their decision was respected, and they didn't get any reprisals. So this is just to conclude that self-care does work, and we have to invest into peers that are motivated, that are supported, and are driven by personal experience in order to provide, to help their social networks. Thank you very much for listening.
Hello again. We encourage all viewers to put your questions in the Q&A box down below. We have a few questions already. I want to thank Colleen and Judith for your contributions. We open it up now for a bit of discussion. Colleen, I'm gonna put out a question for you and then complement as needed, as we're only two here to lead in the panel discussion. So we have a question from Catherine. Do you need to educate the men or husbands so the women will feel safe and ask for services?
Yes. Yes, so I think you can speak to this as well with your work on patient support and community engagement, but community engagement is a key part. So self-care can't be done by itself. It needs to be in a continuum of information in the community support, and accessible health services so that people can also still access health services, and we reduce discrimination within the health services. So I'll let Joanne speak a bit more to how we do a community engagement, but also at the same time, we still acknowledge that we need to work with women to ensure that if men don't support them to access control and options over their sexual and reproductive health, and this is the reality for many women around the world, that we support them to have discrete and covert options. So injectable contraception is great in this way, that it's one injection every 3 months. It's not tablets every day that someone is aware of, or self-managed abortion, or talking about pre-exposure prophylaxis, keeping it at your neighbor's house if your husband doesn't know, so that you can be safe from HIV. So it's a mix of ensuring that women do have the choices and options, even if they don't have support, and at the same time engaging with communities to change attitudes and increase support for women and girls' sexual and reproductive health. Joanne, did you want to speak to the community engagement piece a bit more?
Sure. So let me say a bit about community engagement. We are working necessarily with communities, inside communities, and alongside communities. So when we introduce new activities, we almost always typically speak to people living in those communities. We go towards community leaders, community representatives, and particularly representatives who may be from the patient groups or people who are accessing the healthcare services we're providing, so that they understand what we're doing, the justification for why we're doing it. They have an awareness of the benefits to individuals, to families, and to communities. And so, yes, men for sure are involved in those kind of discussions. And when we meet patients, we encourage our female patients to invite partners as they wish. And we can do that in any form that they feel most comfortable with. And then we also sensitize our teams. So our teams are made up of different genders and orientations. And so we try to have diverse teams so that we can involve all members in understanding the arguments that we have for putting in these self-care interventions. So the community engagement aspect I wanted to emphasize has become more and more important in terms of not just consulting communities about whether this fits their need, but asking them what their needs are, putting in interventions that respond and are adapted to their context, and then involving them perhaps in the actual implementation and evaluations of our programs. So let's see, I'll go to the second question, also very interesting. Janet asks, is the self-care model carried out in refugee camps in conflict zones where emergency medical services are provided, as well as in more stable settings, or is this model more suited to more stable situations?
Great question. I think the answer is a bit of both. So some examples of where we are working on self-care interventions, or where there's more opportunities to do so in conflict and displacement settings, would be in the Democratic Republic of Congo, where we're working to promote the self-injectable contraception is in Eastern DRC, where there is ongoing conflict, and that can fluctuate in different areas and create barriers to access. And further options we're considering is how to support women who are on the move, so either through Libya to the Mediterranean or through Central America, so that they can take contraception with them, acknowledging, unfortunately, that there's this risk of sexual violence on these journeys. In South Sudan, we're working not only self-care, but community-based care. So in certain areas where people are consistently being displaced by ongoing fighting, there's community health workers who we've trained and given out STI, sexually transmitted infection prophylaxis, and emergency contraception pills, knowing that sexual violence is happening as part of the conflict. And so community health workers who then are part of this community can support other women who unfortunately have faced sexual violence. But in other ways, it is really important in stable settings to ensure we're promoting self-care interventions. And this does enable us to do things like the study in Zimbabwe to show the effectiveness and to look at values and preferences in the community and to incorporate it as part of an integrated continuum. Did you want to add, Joanne, from
I think you've done a very good job. It links in with a question I wanted to ask you about how self-care interventions can be integrated in survivors of sexual violence. And you've answered a bit the question. We see it in stable and unstable contexts.
Yeah.
Both.
So yes, so self-care, the idea of self-care is part of how we respond to survivors of sexual violence. So knowing that violence has taken away their agency and their control and choice, we try to restore their control and restore their autonomy and their self-determination through how we provide care. So even in the health facility, we're providing information about the different care options and referral to support services, but it's their choice. But as far as specific self-care interventions, two examples would be contraception and pre-exposure prophylaxis. We know that, unfortunately, sexual violence can be repeated ongoing, particularly by an intimate partner. This is very common. WHO just released a study yesterday that 1 in 3 women around the world experience physical or sexual violence by an intimate partner. So women are often going back to these situations, and so we can give them pre-exposure prophylaxis to take if they choose to go back, to protect them from HIV from their husband, or ensure they have these discreet, covert contraception methods to prevent unwanted pregnancies, and really give them information, or even taking emergency contraception, multiple doses home with them in case this is something that happens again.
Okay, very good. What are some limits to self-care interventions or methods?
Yeah, I think this is something we discussed before this webinar, that self-care can't be done as a standalone service, and it can't be a replacement for discriminatory, exclusionary healthcare. It needs to be a continuum. So we need to ensure that we're providing information to people, and if they do have a complication or a side effect, they can still come back to the health facility. So we are still there to support them. We still need to be strengthening the health facilities that exist. So for example, in Mozambique, where sex workers and gay men were facing discrimination, having a key population focal point, so someone who's a peer, who is a sex worker, who knows all of the healthcare workers at the health facility, who's working on training them about providing non-judgmental care. So it is this continuum, and we can't only focus on these methods in the community.
Mm-hmm. Great. Let's see. I'm aware that we need to wrap up. I think we've covered a lot today. I have a question that's been proposed to me. It's really around how to insert self-care interventions for schoolgirls as part of a health promoting school initiative. And we talked a bit about, I'm certainly very interested in adolescent sexual health and girls' education. This idea of peers is something we've worked in a lot of different contexts and we find very powerful. So people that already young people look up to, so younger counselors, younger staff, and peers of their age can be one of the most important ways that we can introduce some of these important topics. Yeah, so that's a commentary that was from Bear. And from Lena, do you need government support for implementing self-care programs? Do you want to answer that? That's a good way to go into our summary.
Yeah, sure. So I'll just jump back to what you said about adolescents. I think one of the 3 examples of self-care that you gave at the beginning is self-information. And so this is where in some contexts, I know in Haiti, we're advocating for comprehensive sexuality education. So adolescent girls don't only need the tools and the methods, but they need this information. So the government support. So yes, this is needed, especially when there's rules and regulations, including in Canada, about who can provide what medication. This needs to be supported by governments. And so we do work together with governments and ministries of health. And I know that the World Health Organization is also doing a lot of work on this, on looking at how we can promote these options outside of health facilities and looking at the regulations, especially.
Mm-hmm. Good. So to clarify for Lena, the stakeholder engagement is another thing we do, working with partners, working with our other organizations, including ministries of health, is important in terms of policy and advocacy. But thankfully, I think most of you know that MSF is financially independent, and therefore we introduce interventions based on evidence-based and needs assessments. We do that independently, but then work with our partners who are in similar or complementary roles in country. So we need to wrap up. I will hand over to Anam. Anything else you want to add, Colleen, before we finish?
I guess just that self-care interventions is one of the many ways we're looking to promote sexual and reproductive health access for all women and girls and ensure they have control over their health to live healthy, well lives. So I hope we've provided some of these examples to you today.
Thanks so much. A reminder that you can go online to the MSF page. The link might be, if I didn't see it, perhaps we could put the link in the chat. You can go and look at the information on International Women's Day that we've prepared. And there's a small short video in there as well, very interesting and well done. So thank you, Colleen. Thank you to Judith, who contributed. And Anam, back to you.
Thank you, Joanne. So I just wanted to take a moment to thank all of our speakers. So Colleen and Joanne, thank you for taking the time to speak to all of us, and Judith, who's here in spirit. And also thank you to our supporters for tuning in and giving us an hour of your time to learn more about MSF's work. If you have any questions about Doctors Without Borders or our work on women's health specifically, please don't hesitate to get in touch with us via email or phone if you are one of our donors, or via our website if you are a member of the public. Thank you so much for joining us today, and I hope everyone has a lovely day. Thank you.